one of the first and foremost challenges we're going to have is with workforce issues. Some staff have only worked in a single program which has been funded specifically to do individual services, and they have never functioned at the organizational, community, or public policy issue. There is a very different set of skills and competencies that's needed for population-based work than what is necessarily needed for individual work. We also may need interdisciplinary teams to better do this work. Next slide, please. There will also be implementation challenges at the organizational issue or level. Most public health jurisdictions continue to be organized in silos. This is pretty typical: administration, environmental, public health, personal health services, assessment, epidemiology, and health promotion. It's very difficult to try to implement the socio-ecological model and an organizational structure that's organized by programs or disciplines. No one discipline or division is an expert in all levels of the socio-ecological model, and that is why an interdisciplinary team approach is so important in the implementation of this model. Next slide. We really need to explore new flexible structures that better reflect and support the work being done in the jurisdiction. One possible example is what's displayed on the screen, where an interdisciplinary team approach is used with the community as the center of the work. Spokane Regional Health District is currently doing this with a program called Neighborhoods Matter, and we are having some good success with it. Next slide. We'll also have accountability issues. There are not an abundance of best practice methodologies in doing this work. So in many cases, we're kind of creating the practice as we move into it. We also, population-based strategies take time to implement, and outcomes are difficult to measure and may take many years to achieve, which is not always popular with many of our funders. Next slide, please. And of course, there's funding issues. Much of our funding is currently programmatic in nature and pays for a specific set of services or outcomes. Flexible dollars are very limited or totally non-existent in some local health jurisdictions, and grant dollars are becoming increasingly competitive. Next slide. So with all of these challenges, how do we move forward? Well, first and foremost, I think carefully and strategically, but I would also argue that we cannot wait until we have new dollars to begin to do this work. We must be creative and think outside the box. We must use flexible dollars as much as possible, challenge decision makers to be more flexible with the use of programmatic dollars, and assess how local funding is being utilized and reprioritize use of funding if applicable. Next slide. We must, of course, continue to advocate for sustainable long-term public health funding. We must use our existing dollars as efficiently and effectively as possible, and we must be accountable for the use of all the dollars that we have. We may need to look at functional or other type of regionalization strategies, which I certainly realize is a very controversial topic. It's not popular because many counties, of course, fear loss of control, but we must at least be open to having the discussion and beginning those discussions soon. We also must figure out how to utilize healthcare reform dollars as effectively as possible. Next slide. While SAFO does have a key role in moving local public health forward, in order to achieve this, we have developed a strategic direction for 2011-2015. Next slide. this is the strategic direction that we have developed. There are 5 goals: be an active partner in reshaping public health in Washington State, develop sustainable public health business models, strengthen WellSAFO's voice and influence, ensure an adaptable and competent public health workforce, and identify opportunities to advance policy and change in local health jurisdictions. I'm certainly not going to go through all these strategies, which are still draft in format, but if you read through some of them, I think you will certainly see that there are many similarities in these strategies to what we have been discussing. Next slide. The goals that are identified in a strategic direction will certainly stretch us as an organization, and it may also require us to rethink our own organizational structure. We're currently organized into basically 3 different forums: the SELF Public Health Executive Leadership Forum, the Environmental Public Health Leadership Forum, and the Community Health Leadership Forum. And once again, this is pretty programmatic and disciplinary in nature, and we may need to look at alternative strategies of organizing ourselves, which may be around strategic planning goals or very specific issue-based goals. Once again, no one is saying that we must abandon our current structure, but we at least must be willing to examine it, discuss it, and change it if, in fact, it looks like that's the appropriate way to go. Next slide. Well, SAFO and local public health, as it does have an opportunity, I believe, to truly reinvent itself, but we must do this carefully and strategically. We must have a strategic direction and plan that allows us to anticipate and adapt to our turbulent, changing environment, and one that will provide hope for the future. Local public health will exist after this crisis, but I am convinced it will look very different than it does today. Next slide. The chance to reshape our future is now, but it will require creative thinking, bold leadership, and a willingness to take risk. Thank you very much.
Thank you, Elaine. So we'd like to invite questions at this time. I know Betsy has been asking in the chat box. If you have any questions, please, for Elaine, put them into the chat box, and we'll give a couple minutes for people to do that. All right, are there any questions, Betsy, coming through?
No, none have come in right now. So we can always we have extra time at the end for questions that come up as the presentations progress.
All right. All right, thank you again, Elaine. I now would like to invite our next speaker. Here is Barry Kling. He is our administrator for the Chelan Douglas Health District. Very active in many roles of public health and public health leadership throughout the state, and has been a good voice for public health in the direction that public health is now going. So welcome, Barry.
Thank you. Can you hear me okay?
Yep.
Well, very good. You know, I have heard of an ancient Chinese saying that danger is the same as opportunity might have resulted from someone who couldn't spell. Because I think that we face some dangers and have already lived through some dangers that aren't really opportunities. So I'm going to be a little bit less visionary and positive than what you just heard. And I guess that's partly in reaction to the fact that I've been in a lot of these discussions now about the future of public health. And it seems almost unavoidable that they veer into a discussion of new and wonderful things that we really would like to do, but which we unfortunately don't have the money for. And I think the situation is a little harsher than that. I like to think visionary and positive and expansive terms too, but what we face today is a pretty serious situation that raises some very basic questions. So I'll give you that as a preface to these slides, and please give me the next slide. And then the one after that. Now, one of the interesting things is that here at Chelan Douglas Health District, which has been cut in half since I arrived here in 2003 in terms of FTEs, most of the erosion happened before the recession hit. So this isn't just a passing fancy that's a result of the recession, and once the recession's over, we're going to bounce back. And of course, as Elaine said, it's a statewide pattern. And at first, we were focused mainly on, well, you know, what do we cut? And that wasn't too hard of a question, because usually it was categorical money being cut, and we cut the things that nobody would pay for anymore. But as the cuts got deeper, we started really looking at it more in terms of what to keep, because when you lose half of what you had, when you're especially hard hit in areas that aren't fee supported, you have to think about what's the essential core of public health that we have to preserve, and that's what I really want to focus on. Next slide, please. Next slide, please. Oh, there we go. I'm sorry, go back one. We were out of sync. Go back one. There we go. So, and now we're at the very beginning. So we're going to try this one more time. Go forward one slide. Good. So everybody agrees, or at least almost everybody agrees, that public health is a basic responsibility of government. Even around here, we don't have very many people who think the government should do absolutely nothing. And public health is one of those things. But which of these public health functions aren't optional? And I think it's helpful to think about it in terms of what's not optional if you're going to have a civilized community, in the same sense that if you don't have any law enforcement, and you don't have safe roads, and if you don't have fair judges and fair courts, those are the very, very basic hallmarks of civilized communities. And so what's the public health equivalent of that? What's really the basics? Or are we just a contractor that happens to do a bunch of health-related programs, and when the money goes away, we just stop doing those programs? The question is, what do we bring to the community that the community's not going to have if it doesn't have a public health department? Next slide, please. And I think we have to answer these questions clearly in terms of what the basics are, not just in terms of what we'd like to do if we had a whole bunch more money, because if we don't define ourselves meaningfully, other people are going to keep doing it in ways we don't like. Next slide. Now, we've tried to answer some of these questions before in a sense. You know, we have the 10 essential services, and I was part of the 5930 effort that some of you remember to define core public health functions of statewide significance. But what happens is that when you sit down with a group of public health experts and you ask them to define the government's basic public health responsibilities, you just happen to end up with a list that looks just like the things those people are doing. And that's not really a coincidence. That's understandable. But if you look at the 10 essentials, or what we came up with in 5930, they're very broad. They define the broad scope of what public health could be. And no health department I know of has ever done anything that isn't included in these lists. But that's not the question that I'm posing anyway. My question isn't what's everything we could do. My question is, now that we're cut in half, what's the minimum? What should we keep doing? What should we fight to retain because maybe we haven't bottomed out? Next slide, please. So what's missing is boundaries. And this matters because to rebuild public health, we have to clearly explain what those basic governmental public health responsibilities are. And to do that, we have to talk in terms of what's included in that list, but also that means what's not included. Next slide. So we need a clear and explainable principle that goes beyond who happens to be on the latest committee that made a list. We need a clear principle for determining what's basic governmental public health and what isn't. And I suggest that we really already have one. It's not rocket science or anything new. It's the basic principle of epidemiology, the population-based principle. epidemiology is the basic science of public health. Next slide. Epidemiology can be defined as the study of patterns of disease and disability in populations as opposed to the study of diseases in individuals. It's the basis for public health as a distinct field, and I suggest that it's a principle that can be used to define the boundaries of governmental public health responsibilities. Next slide. So what is a population-based public health function? Well, it would involve an intervention that serves mainly to protect a population from a health threat rather than to address a particular individual's health needs. And one of the peculiar things about it is that in a purely population-based intervention, the benefit is real and predictable, but the individual beneficiaries can't be identified. And I want to give you some examples. Next slide, please. Suppose we're preventing chronic disease through health promotion. I said health promotion because that's a joke that we make sometimes about what's going to be left to us. But we're preventing chronic disease. We're doing communicable disease outbreak response. We're responding to the outbreak and trying to limit its further spread. We're able to help provide clean drinking water. So if your local health department does all those things, helps people live healthier, makes sure their drinking water is safe, quickly controls infectious disease outbreaks, so your department's doing a great job, which one of your neighbors didn't get sick as a result? You don't know. You know there's a benefit, but you can't identify the individuals who benefited directly. And I'm making a point of this because this is one of the marks of a population-based intervention, and it's one of the reasons it's up to public health. Next slide, please. Because in the absence of the individuals who benefited, you don't have the normal incentives that you would in a medical problem to treat the individual and charge whoever's responsible for that person's health care. The normal incentives don't work. And that's why a population-based intervention has to be done by the community. If it's something that could be done by many other parties, but just happens to be done by public health because of tradition or we landed the contract or whatever, it can be a wonderful thing. It can be great, but it isn't a population-based service. And as I'll suggest further, it probably isn't as central to public health responsibility as other things. And here, Elaine and I are saying very similar things. Next, please. Next slide. Now, there's some functions that are kind of mixed. Think about taking care of an indigent TB patient, a person with active TB who can infect other people. Well, we care for that person partly for that person's benefit, of course, but also to protect the public from exposure to that disease, because if we don't care for that person, nobody else will. Many vaccines fit a similar pattern. The individual gets the vaccine benefits, but we're involved also for the community-wide benefit that an adequate immunization rate provides. Next slide, please. So we're unique within the healthcare system, even after health care reform, although I tend to try to call it health insurance reform because that's what it is. It isn't actually changing our systems functioning very much. It's simply making sure that more people are covered, and that's a wonderful thing. But it isn't changing the basic dynamic of how money flows in the system. So we're unique within this system in that we have a mandate to look at overall population health and to consider health issues from the perspective of the entire community. So I would suggest we're primarily responsible for the population-based functions that aren't otherwise addressed by our individually oriented healthcare system. That kind of puts it in one sentence. Next slide, please. So I just want to emphasize that this sounds a little abstract and maybe academic, but the reason it's important isn't abstract or academic. It's important because the more population-based a function is, the less likely that it's going to get done unless public health does it. And some of these things just don't get done at all when public health doesn't do them. Next slide. Now, I'm going to move rather quickly through the next few slides because the point is simply that this principle can be applied systematically, that one can look at the things we do and answer three simple questions about them. The first is the extent to which it's a purely population-based function in the terms I've just discussed. The second is, do other organizations other than public health also do this service, or could they also do it? And third, is it legally mandated for public health? Because that kind trumps the others. If we are legally bound to do it, then we have to do it. Next slide. And what I'm suggesting is that you can use these ratings to give to rank public health functions in different levels. And I'm using the term core, and pretty soon I'm going to show you the obligatory diagram that shows the core in the middle and the other things surrounding it. And the point is that the core functions, the most central functions for governmental public health, minimum basic activities, are population-based. That's the core. David Fleming of C. King uses a very helpful analogy here about the other things, because there's some other things that we have traditionally done, like nursing home visits, that are very, very valuable. And to say that they're not in the very core doesn't mean they're not important. It's a little bit like organs in the body. You know, the brain and the heart are central in the sense that you can't live without them. But in saying that, nobody's denying that you want to have healthy eyes and arms that work and legs that work. So, you know, the point is, what's the core here, not what's important. There are things that aren't in the core that are still important. Next slide, please. There's the diagram. Core functions in the center. Those things like controlling communicable disease outbreaks are clearly in the core. Things like treating a TB patient are core-driven, but they're still individual services. That would be in level 2. Level 3 would be some of the traditional public health services that are individually delivered, not really population-based, but are still valuable because of their long-term benefits. Next slide. And I'm going to go quickly through the next few. This is just a result of one person's rankings, giving points to each of the answers to each of the 3 questions I mentioned. And we're not really focused on the details of this today, so this is just what ends up in level 1. You can see that there's the really central basic things. And under health promotion, disease prevention, this list lumps some things that you might not think of under that heading. That's outbreak investigation, immunization promotion, the basic environmental health protections we've talked about. So all those basic things are in there. Next slide. And let's just jump through the next 2 slides, because these are the other levels. And the details aren't really the point. And one more after that, please. And here it is again one more time, the obligatory diagram. Next slide. And I just want to spend a couple more minutes talking about the implications of this way of thinking about what public health ought to be doing. It suggests that those core functions need to be served in every community, that they're part of what every civilized community has a right to expect for their citizens. And it includes some familiar things like communicable disease control and basic environmental health protections, but it excludes some familiar things. Now, those things are still valuable, but in a situation where we've been cut in half and can't even do all the valuable, what we think of as basic things, when we have to choose, like we have to choose today, some of those things have to go by the wayside. And part of the idea here is that a local board of health, equipped with a staff capable of doing those core functions, will know what its community needs and will be driven to try to find resources to do other things beyond the very core. So it's consistent with the idea of local control. In fact, it depends on it. Next slide, please. So you could estimate the cost of providing these core functions in various communities and work toward a more rational funding system, and I think this is one of the sub-goals that WASELPA is interested in, where you set up some kind of formula that provided this basis for building a greater public health system upon it, but these basic functions that you need as a foundation. And this may seem like a silly thing to talk about at an anti-government moment like this in history, but we've had this twice before. That's what MVET was until the initiative petition zapped it in '99. Previously, in the 70s, there was a millage that supported basic local public health. And if we are ready when the moment comes, and it will because the pendulum will swing back, we will have an opportunity to hopefully reestablish a base for a sustainable basic local health system in the the minimum that you're a civilized community ought to have in public health. And one of the things that's difficult, though, is to look ahead far enough to do that. We've been really caught up in fighting session by session each legislative battle, and this is something that could take some time. Next slide, please. I should mention that I talked mostly about local public health, but DOH has found some of these ideas useful in making some of their decisions in the last budget cycle and in the upcoming one. And I think I'm going to leave it at that and leave the rest for my colleagues and for any questions and answers, because I think I've made my main point that we need to look hard at what we're doing, focus on the population-based things with especially local money, and we have to, if we want a sustainable base in the future, we have to be able to answer the question, what would it do? What would it do if we got a base of local funding that we knew we could count on instead of being a political football? And that requires some hard thinking, not just about what we'd love to do if we had the money, but what we do when we have half of the money we used to have or less, because that's the situation that we're really moving into. So thanks for listening.
All right, thank you, Barry. I know that there are a couple questions that have come in during your presentation. So Betsy, I'll let you direct or ask those questions.
Okay. The first question is, does the core ever change? Does current mortality and leading causes of death drive what is core?
Well, yeah, and of course I did skip over a lot of that pretty quickly. But the idea is that one of the basic functions is to know what the health issues are for your community. And so that basic assessment function is right in there in the center. And the idea is that if you have a staff that can inform a Board of Health about that, that will provide some direction as to how to focus the other resources. So, and of course, you know, you can't, decision makers who say, well, what really is basic public health? They want a shopping list. And you really can't give them a shopping list. And we know that from practice. You know, there's communities where public health has to give a lot of immunizations directly, you know, put the vaccine in the arms because there aren't many providers. Other public health districts or jurisdictions don't do that because there's plenty of providers around. And both of those are appropriate to those localities. So the idea is that you have these basic capacities built in. You have the ability to promote immunizations. And if you're in a, and again, we're talking about the basics. So there's no guarantee that you can directly deliver all the individual healthcare services that are needed. But it's not a rigid set of services that, you know, can't change as conditions change.
Okay, our next question is, are there any strategies to help us stop clinging tightly to our silos, and how do we create interdisciplinary teams?
Well, I don't, you know, the main problem there, the main thing that creates silos, in my opinion, is the funding. You know, if you're getting money to do service X and cut service X, you lose that money. So, you know, you can't say, well, we're not going to do service X anymore. We're going to use that for our interdisciplinary team that happens to be doing something else. So as long as the money comes down those silos, we're going to have that issue, and that'll continue to a considerable extent. But that's where this idea of a sustainable base comes in. There needs to be, and we do have some flexible funding. That's what we fight hardest for in the legislature. But it's a pretty small proportion of what we have right now at the local level. But that's the reason for that kind of funding. Some sort of system that tracks reasonably well with population growth and doesn't depend on the, you know, whims of some legislator who doesn't depend on what diseases prominent legislators' family members got and they cause us to go after for the next several years. Doesn't depend on whims like that. So, you know, I honestly don't think that other than funding flows, there is a lot of problem. Here, we've had public health nurses and environmental health specialists working together readily on foodborne outbreaks. You know, nobody, when we started doing that, you know, the mine police didn't visit and tell us we couldn't do it. It's not that hard to do.
Okay, we have another question that just came in. Although some functions are mandated, the laws rarely define the extent to which public health must do what the laws require. Should this be a strictly local decision, or should the public health system define adequate functionality?
Well, I'd point out that right now we have neither. As you said, there's no law that really says exactly what we're supposed to do, and we're unable to give very clear answers to that question ourselves. I think that the best approach is for public health to give very clear answers to that question as part of the development of a sustainable funding base, and that we be held to some broad standards that could be monitored by some outfit like DOH. But the whole point is to provide a foundation, not the whole skyscraper, but the foundation, and for that to be under local control within broad guidelines that clarify the kinds of functions that are performed. So, for example, you say, you need to be able to assess the problems of the local population. That doesn't say what your findings have to be. It just says you have to have the capacity to do that kind of work. And similarly, with regard to basic environmental health protections like food service, you have to have a permit-based system that regulates the safety of food that's served to the public. So, I think, and our problem in defining that base is not listing things to do. We can list all the specific things we'd like to do. Our problem is putting boundaries around it and saying what's in and what's out when you have to choose.
Okay, that
All
looks
right. Thank you so much, Barry, and also for the questions come in. Those are great questions and some good thinking around that. So we're going to move to our next presenter, who is John Weisman, who is the Director of Clark County Public Health. John is also the Vice President of the National Association of County City Health Officials. And another one of our panelists who is a thought thinker for our public health system here in Washington State. And so we're glad to have John join this panel as well. And we are moved to John now at this time, and then questions at the end. Thanks, John.
Great, thank you, Dennis. No pressure here, a thought thinker, huh? I want to thank, first of all, WSPHA for hosting this webinar and a chance for me to sort of step back and reflect a bit. Like Barry, I hope to maybe take a few things and be pretty direct and maybe even take a few risks. And as I do that, I want you to understand that those risks or challenges are not just for you. They're things that I need to challenge my own thinking about and my public health practice. So as I do this, it is not targeted at anyone, but rather for all of us to think about it. When we were asked to put this together, we were asked to think about local public health priorities, what they should be in the process. I hope to answer that, and to do that by hopefully taking a broader, maybe systems approach and leadership-based orientation. These documents I know will be made available on the web afterwards, and Betsy, I'm going to send you 2 other documents tomorrow that can go up too. For those of you who are listening, a framing document that we've used in Clark County Public Health that will take some of the things I'm talking about to another level. So I'm going to end up focusing on 4 areas: the what, the how, the system, and leadership. And we'll do that throughout this presentation. But on this first slide, I think it's important to focus on the fact that we are about healthy people and healthy communities. So let's go back a slide. Let's not quite move yet, thanks. In the center of that target is outcomes, and I think this is the first challenge I have to myself, to my department, and to us as a system. I don't think we know what it means when we reach healthy people, healthy communities in our state and in our system. We've not defined what specific outcomes are we looking for, nor what specific outcomes we're prepared to deliver on with whatever resources we have. And if we've not identified clearly the outcomes, then selling public health to anyone else, I think, is a major challenge. Now, I will say that there are some exceptions. I think we did this very well with the tobacco plan, for example. A great plan was put together with targeted goals, targeted programs, targeted outcomes, and a lot of resources consolidated and put towards that approach. I think that was a success, and I think we need to be looking towards that as a model for us to continue to have successes in other areas. So the first point is, what outcomes are we really after? What outcomes are we after in our local jurisdictions? And what outcomes are we after in as a system? Right now, my belief is we are more geared towards what kind of services we provide, whether those be individual services or population-based services. So with that as the intro, let's move to the next slide, and that would be the what. I believe that truly as a system we have defined the what, and that what is encompassed in the Agenda for Change document that was produced last year. That was produced, as many of you know, I assume, by a group of practice and academic folks from local, state, federal, tribal, the healthcare system, academic systems, in a room thinking about these things. There was an advisory group. There were conference calls for many people to give input into drafts of those, of which hopefully all of you on this call participated in. There were presentations at Joint Conference of Health and email input. So my point is, while I'm sure that none of us got everything in that document we would have wanted to have in there, it is a very good collection and representation of where we as a system need to go and what we need to focus on. And in particular, the things we need to change. And as a quick refresher for those of you who don't remember, the three things were really that in communicable disease, we have to focus on capacity and enhance the most effective and important elements of prevention, early detection, and swift response. So there's a piece about, do we really need in communicable disease to keep doing everything we're doing, and do we have the evidence base for what we're doing? The second piece is to focus on policies and system efforts, and that's the major change here around what it means to foster healthy communities and environments that promote healthy starts and ongoing wellness and preventing injury and illness. So basically, we've got to think as policy and system more so than we have been. And then the third piece, which we in the public health community have struggled with, and this is a place where I've had to move out of my own personal framework as well, is that with healthcare reform, it's time that we in public health more effectively and strategically partner with the medical care system. We've divorced ourselves from that, and I think that's been a huge mistake, and I was one of those who did that. So from my perspective, the what is out there, and it is true that our own individual communities, we may have another issue or two which may not fit quite so neatly there, that is indeed a specific issue to our jurisdiction that might not be as much of a problem elsewhere when you look at community assessments. And those certainly need to be addressed in those communities. I think that it would be interesting if WSALFO took the opportunity to pull together the strategic plans from all 35 local health jurisdictions and see what kind of consistency we have in terms of our strategic directions. But basically, on the what side of this, I think that we need to call this done and move on already. We know what the what is. It is time to deliver. So moving to the second slide then, the how. I'm going to actually go back to a slide, not a slide per se, but something that Elaine started out with. I really do think that we need to train all of our staff and adopt into our practice the socio-ecological model, and to do so very planfully and consciously. The models, you remember that Elaine had up there, has the 5 different levels, working at the individual level, the interpersonal, the organizational, the community, and public policy. It is important for us on anything we want to move the needle on that as a system, and as a system not just of governmental public health, but a system of community partners, federal, state, local, tribal, academic, the nonprofit sector, schools, businesses, all those people who are part of the public health system, that as a system, we choose what outcomes we are going to work towards, and have interventions at each of those levels that build upon and support each other. Without that, we're not going to have the kind of impact in reaching the needle we can. I think it also gets back to Barry's point in his slides, which is as we do that, we have to ask who are the partner organizations or the partners who best provide that level of service. So as Barry indicated very eloquently in terms of population-based approaches and his framework of identifying that as governmental public health work, I think we need to take that, embrace that, and think about how all those levels are covered in our communities on common outcomes that we are working towards. And again, I think tobacco is a great example that we did that as a system. We also need to, obviously, I think, focus on the social and behavioral determinants of health, understand some of those root causes around lack of education, racial ethnic disparities, and how racism is a piece to poor health, income issues. So we need to understand those, be committed to that in terms of a social justice approach and health equity. And I think what I didn't put on that slide that I should have as well is we need to use the evidence-based programs that are out there. There are things like the Community Guide to Preventative Services and the Clinical Guide for Preventative Services that are established. They're out there. But the question is, are we really using those things? And I'm not sure that we are to the extent that we should be. So it's there. We need to train people on these approaches and make sure that as we plan programs, as we develop our logic models, that those things are built in, that that's our building block to be successful towards achieving the outcomes that we need to achieve. Betsy, if you can go to the next slide, please. So then we come to the system, and I would argue that our local successes have to be linked to state successes. If for no other reason, because certainly there are significant chunks of funding that are coming from the federal and state levels to us locally. The outcomes that I think we need to establish truly is statewide goals and targets that are achievable based on what the epidemiology tells us and what the evidence-based practice tells us that we should be able to gain if we implement programs at all levels of the socio-ecological model. I think we have to model out those outcome changes and be clear about them, and as a system adopt those. And for local public health, that means that we have got to think not only in our own community and our priorities there, but how they do connect statewide. Many people move across geographic boundaries, and as we start thinking about the population more like a health plan thinks of its patients as its whole service area, I think that's important. So that gets to the piece on the slide that says that we need to plan and prioritize globally, but implement locally. So as a system, I believe we have to come to targeted outcomes. We cannot do everything. There is not the funding to do everything. So what is most important for us? Where do we think we can move the needle, and how do we go about doing that? And then locally, we can figure out, using those best practice models out there, what works in our community. What is our community ready for? Where do we have partnerships we can already capitalize on? So plan and prioritize globally and implement locally. And in implementing locally, I think we need to take a look at regional collaborations. We need to have this discussion around how can we make best use of resources, how can we work across jurisdictions to share resources, to identify who's got maybe a particular skill set that could be shared across multiple jurisdictions. The issue of whether or not jurisdictions actually consolidate into one is really a political one that I think our local boards of health and commissioners are going to need to sort out for themselves. Where is it that local control is now balanced with, gosh, what resources do they have to make an impact, and how does governance occur? So I think that's a political question that more and more jurisdictions might ask as we have limited funding. And thanks, Dennis, for the 5-minute warning there. The other thing that I think we need to do is look at the financing system. I believe the financing system is currently broken, and that we need to get our minds around this with key legislative champions, with the executive branch of state government, with key statewide partner organizations. And I think we have to ask, what are we going to buy with the state dollars and federal dollars that are available to us? How can we pool those together and direct to common statewide goals? And sort of getting at what Barry was talking about, what is core level 1 services, and is that a service, for example, that we think should be funded with state dollars, and then that local priorities be funded with local funding? I think we have to be bold and proactive as we start doing this thinking as our starting place, come up with models that maybe we're not going to implement, but models or be able to implement politically, but models that start thinking us differently about how we actually finance this system. And to Barry's point, we need to introduce legislation starting next session that starts moving us down that road. And knowing that it may very well not go anywhere in this economic climate, but we need to put it out there for that time when it is going to get traction if the next session isn't that. And then my last slide, please, Betsy, talks about leadership, and all of this is going to take incredible leadership. I think at the local public health level, we as local public health officials need to get at the power tables in our communities. We need to get at those places where people who have significant influence over priorities in our communities, the money, the power are. Those could be things like hospital boards that we need to get ourselves on, economic development councils. We need to, if we're not there, really think strategically how we can get to those places to build the connections and gain the power that we need. At the local level, I think we need to pick a few focused partnerships that can really get at the outcomes that we're looking for, and have, again, broad base of those. Washington State Public Health Association, I think as part of this, you need to do more of what you did this year. I'm really pleased with the advocacy work I saw you all do for a broad public health agenda, cross sectors with multiple constituents coming together to work and truly to fulfill your mission of being the leading advocacy organization voice for public health. I think that's a positive to get that main role out of WSOLFO. And that you're a place that you can bring together this government and non-government. For WSOLFO, and I'm almost done here, for WSOLFO, I think we have to stop whining. We have to identify our dreams. We have to get to the task of making them real. While we have to indeed think about how we move as a system, whether we're small or large jurisdictions, urban or rural, east or west, liberal or conservatism communities, we have got to get past that and start working together. And finally, for the Department of Health, I think we need that leadership with WSOLFO's executive group and leadership to pull us together and identify these very clear targeted statewide goals. Pool our funding for use, much like what is happening in the division that Sue's running in terms of thinking about how we address chronic disease. And I think we need to increase our risk-taking. We need to act like we have something to lose because we do. Thank you.
All right, perfect. Thank you so much, John. All right, I know several questions came in while you were presenting, so Betsy, I'll turn it over to you for questions.
Okay, the first question is, under your HOW outcomes, what is the role of public health in doing advocacy or convening coalitions for advocacy?
I think it depends on how to best move something in a community, which you need to assess politically. Definitely, public health can be a convener, pull together coalitions, bring together people who can come around a common focus, some common outcomes, and then use those organizations to push key policymakers or organizations into action. And so we need to understand how you do that in terms of skills, how you facilitate coalitions, and maybe in some cases not even facilitate the coalition but be the partner. So the point is we need to develop the skill base. We need to figure out, based on local conditions, who can best take the lead, how far we in governmental public health can go with that in our community, and who has to sort of step up if we can't. And so the answer to that is both a general one about developing the skill sets, but specifically needing to evaluate each situation.
The next two questions are similar, so I will kind of combine them. The county is an obsolete jurisdictional model, serving best in an era when all government needed to be was within horseback distance. However, the county structure is politically etched in stone. How should we move to a regional structure? And then the second part of that question is that funding seems to follow county lines, and so do you have examples of how regional collaborations have worked?
Good questions, and this is not for the faint of heart, I can tell you. We down in Southwest Washington have done this when we did H1N1. We actually, as 4 local health jurisdictions and the Cowlitz tribe, came together to delegate our response for 5 independent jurisdictions to one single incident management team. That is a way of bringing together resources throughout a community to minimize the overhead in the incident management team. And so I think if you want to read more about that, go to the January issue of the Journal of Public Health Management and Practice, where we've written that up in the article. So I think you need to think through where your skill sets are, where you have resources, what you're prepared to come together across jurisdiction boundaries to work on. And again, and I agree, political boundaries are just that. They're artificial. So it comes down to leadership and people thinking about what makes sense for the issues you've got in front of you and where you can partner. The political piece about, as I said, consolidating or whatever, politicians are going to need to figure that one out.
This is Barry. If I could just jump in for a minute. In the room with me is a regional epidemiologist, Jackie Dawson, who serves 5 counties, 4 health jurisdictions, and has been doing that since, I think, 2005, in supporting basic communicable disease as well as emergency preparedness. So there are examples like that around the state, doing exactly what you said, not waiting for politicians to change the boundaries, but functionally sharing activities where it makes sense.
Exactly, good example.
All right. Betsy, is there any other questions?
No, that's it for now.
All right. Thank you so much, John. We're going to move on to our last presenter. And I first came in contact with Scott when I was a TB program manager and really got to know Scott's passion about TB, but also just about how to work public health and really close health disparities. And I just really learned a lot from him during that process. So very glad that he has joined us. Scott Lindquist is the health officer and director for Kitsap County Health District, and we are honored to have Scott join us as our last speaker, but we'll have lots of questions for Scott as well, I'm sure.
Okay, and Dennis, can you hear me okay?
Yes.
Okay, shout out to the Kitsap County group in the other room, who's all there. There's about 20 of them. So what I want to talk about is a really pragmatic approach to all the things that we've talked about. And let me just state this up front. I agree with what everyone says on the phone. I really like this forward thinking or even this introspect about where public health is. But I'm going to take a very pragmatic stab at this, and we're going to do it with not a lot of words. We're going to do it with a good picture. And basically, over the last couple years, we have really looked at what has been the history of public health in Kitsap County. And I have read the Board of Health minutes, every single minute, from 1940s to the present. And I got to tell you that Kitsap is in a position it's been in at least 7 times in the last 70 to 80 years. So this is nothing new that we're into now. Yeah, there's some new twists, but really what has stood the test of time across all kinds of ups and downs in economy, world wars, etc., has been some themes that are going to be represented in what we functionally call the house here in Kitsap County. And I'll tell you up front, the roles that seem to stand the test of time are nurses, public health nurses, sanitarians, okay, and when I say sanitarian, I'm not talking about an on-site sewage specialist or a drinking water specialist. I'm talking about an environmental health sanitarian that can do all of the above. The other thing that stands the test of time is administration and a health officer. So based on this history of multiple ups and downs through our history of the last 80 years and what's really stood the test of time, we created what we consider the base model of what public health into the future should look like. And the first thing, as you look at what really is a basic tenet of health, is good housing. So the role of public health in Kitsap County should really center around making sure every socioeconomic class has access to safe and affordable housing. You can see here on the diagram that this house also has a chimney in it, so we're talking about indoor air quality. Whether you're in Guatemala or you're in Kitsap County or you're homeless in Kitsap County, you should have some basic tenet of housing. Next slide. So in Kitsap County, you can apply these principles to what is a burgeoning population of homeless folks here. So while you may say a tent in the woods is not good housing, it may be the best we can do. But here's an application of housing in modern day public health concerns. Next slide. One of the big tenets, whether you're homeless in Guatemala or you're in a house on Bainbridge Island, you must ensure clean water. So clean water coming into the house is something that I don't think we champion in public health as much as I think we need to do now. We need to really champion how good our water programs are, how important they are, and really follow indicators of how many clean water days we actually have. Now in a county like Kitsap, water isn't just drinking water. We are surrounded by Puget Sound and we have rivers and streams. So water is one of these basic tenets of the new public health model. It looks very much like the old public health model. Next slide. And managing sewage going out. Basic tenets, like if you're a homeless person living in the woods, do you have access to clean water? So do we as a public health system ensure that there's water that's clean? And there's appropriate sewage disposal. In a homeless shelter, that may mean Santa cans that public health helps foster through partnerships. Or it could mean sewer systems or septics. And basic questions like, what is better, septic or sewage, can be answered if we really monitor. By the way, 2 million gallons of raw sewage are spilled in our county through sewer systems every year. And we have a very tight O&M program. There's no way we spill that much through a septic system. So bringing data to the table about what septic systems function the best, have the highest failure rate, you'd have to say sewers aren't looking so good now. This kind of goes against basic tenets. But next slide. Garbage. we have to have some form of solid and hazardous waste management. Now, in our county, we're a military county, and we have a lot of solid and hazardous waste sites throughout the county. Missile sites that have exposure to diesel fuels and rocket fuels, or just simply rats and garbage management that we all deal with. These are the basic tenets that we have done over the years, that we do well, that we need to champion into the future. Next slide. What this garden really means is the basics of good food. And when we talk about good, healthy food, the movement for us is more from farm to table, sponsoring farm and school partnerships, pushing organic foods, making sure that we don't have grocery deserts in our county, that low socioeconomic status has access to cheap, good foods, not just through a 7-Elevens, which, by the way, are popping up all over our county. Next slide. Having a nurse that does home visitation. And for us, that it really means scaling back down to the highest risk, which is first-time moms, and low income, unfortunately, at this point is where we have to target, but also looking at programs that actually have a return on the investment. So how many dollars do we save in child welfare or incarceration? These are the basic tenets that have stood the time in Kitsap. So yes, it means we're being more creative. So approaching the hospitals like John talked about, our hospital funded us $100,000 to reinstate portions of our home visitation program. That's the new model. Okay, next slide. This is really immunizations. This is the one thing that public health has really changed the face of humankind over the last 100+ years. And that is something that we feel in Kitsap you really need to stay an expert in. This also represents our communicable disease response. Population-based control of communicable disease of public health importance remains a tenet of public health in our house model. Next slide. That's great to look back, and it's good to look at the trends over time if we were going to just continue to do more of what we do now. And that isn't the luxury we have. Well, these are basic tenets that we must stick to, looking forward into policy development to address issues through strategic planning is really our future growth in public health. So what that means, obviously, it's smoking laws, it's clean air ordinances, it's calorie labeling, it's recommendations for food requirements in schools. It is really the role that we're asking our Board of Health to really step up and become policy experts and really wield the power of public health through policy, as we don't have the staff that we once had. That means for existing staff, everyone has to learn the basics of policy development. Which policies are the first priorities? How do you create a prioritization process? Who writes the policy? Who has the final say on it? How do you advocate for it? How do you market it? This is really the change in our traditional public health that really fits our house model. So what I've done is shown you in schematics some of these big concepts of what everyone has talked about before and what we could do in our own personal local health jurisdiction, looking at our history and our current needs. And this really looks like what our public health is going to look like for the next decade or so. And I believe that's the last slide.
All right, thank you, Scott. Betsy, I'll turn it over to you for questions.
Okay, we have one question right now. We are seeing a national movement towards policy and system changes and a move away from individual services. Can you share your vision of public health nurses in this work?
Yeah, and so if this question is directed to me, this is something that we quickly realized that while we lost funding for some of our home visitation programs for nursing, we took one of our young nurses and said, we're going to redirect you into policy development. You need to learn the skills of policy speak. You need to learn how, and there's great trainings that are put on by Department of Health right now. She's in the midst of really going through this, leaving behind her skills as a home visitation nurse, and actually learning a new language of policy development and applying this towards what we are calling our chronic diseases model. So she is becoming the chronic disease nurse specialist. So she's going to be an expert in clinical medicine. She's going to be an expert in partner development. She's going to be an expert in advocacy. She's going to be an expert in policy writing and development. That's the future for a segment of our public health nurses.
How are you training existing staff to do policy work?
Well, the first thing is there are a great series of about 6 trainings put on by DOH, and one of those that is really specifically geared towards how to create a policy program within your own local health jurisdiction. I was a bit surprised that we weren't more mature as a public health system on how to do this, but that's really where the predominance of our training is coming from. They're great trainers. They're national trainers that DOH is flying in. And if you haven't enrolled in these, they've been in Everett for us, so in Snohomish County. We've got a lot out of these to really give us aha moments.
Okay, the next question. The Kitsap County structure may have been appropriate for the past 50 years, but that was before the internet, obesity epidemic, and designer drugs. How does the old model really address the future?
Well, I think the future is you cannot, even if you look to the future, you cannot ignore the things we do well, okay? We do water well, we do sewage well, we do garbage well, we really do home visitation and immunizations. These should be applied to a population-based approach, okay? So it doesn't mean doing well child clinics, it doesn't mean necessarily doing individual services. And the future for us is data. So really investing in our epidemiology and saying this as we create a strategic plan that one of our core drivers should be what our data shows the direction we should go. And that direction, so you got to invest heavy into epidemiology and information technology at the expense of cutting individual health services and using policy as your most sharp tool in your adversary. So policy development towards the goals, and obesity clearly would be on the radar as a chronic disease. I would actually say probably our most common thread would be hypertension, but obesity, diabetes, these are all going to be important things in the future, approached through population and policy. That's the future.
Any other questions?
Yes. Where do public arenas, the commons, fit into this model?
I'm sorry, I didn't. Is that directed to me?
Yes, that is to you. Yes.
Can you say it again? I didn't quite understand.
Where do the public arenas fit into this model?
Well, I'm not quite sure what they're asking, but here I'll tell you what I think the public arena. I think really Kitsap County, one of the things we have to get together is the public as a community. And that's no easy thing to say that your county really thinks like a community, because it doesn't. It thinks like a silo. And it thinks like cities. It thinks like a naval shipyard. And what we're going through now is this community health planning process where we're bringing all the community members, including a real emphasis on the business community, to come together and articulate what our priorities are for health for this county. Not just public health, but health. The hospital, mental health, drug and alcohol, everyone coming together as a public to say, we all agree these are our top 5 priorities for Kitsap County, our community. Now, there's going to be differences in opinion, there's going to be data that's brought forward, and you have to reconcile differences of opinion and differences in priorities versus what the data really shows. That's our role, convening these community think tanks and groups, and it's a big process, and bringing data to the table through epidemiology.
Okay, and we have one last question. This actually came in for Barry, but it's I've opened the floor up for questions for all the presenters now. So if you have any other questions, please send them in. And this question is, would you create a funding mechanism that recognizes differences inherent in the variations in the size of a county?
Well, I think it's a political reality that that would have to be done to some extent, but I think it should be a pretty limited extent. And I say that as one of the smaller jurisdictions in the state. I believe that you could structure it in such a way that you get, you start talking about modeling, how many FTEs does it take to do the basic things you have to do in a 100,000 population or a 50,000 population. Well, you get down to portions of FTEs pretty quickly, and it seems to me that one of the strings attached has to be that some of that's done on a regional basis along the lines John was describing. So, I think there can be some of that acknowledgement of the extra cost of doing business in a dispersed population, but there has to be, along with that, some force toward regionalization. And the argument doesn't run all in one way. I've worked in cities and in rural areas, and it's harder to do some things in cities. So I think that can be overdone, but it needs to be part of the picture.
Any other questions, Betsy?
No, yes, one just came in, actually. This is for all the speakers. What are those public health functions that should be regionalized?
Well, this is Barry. I'll take a real quick pass at that. I mentioned communicable disease already to our regional epidemiologist. I think assessment is a no-brainer. It's really easy to do that on a regional basis in the sparsely populated parts of the state. And I think that anything that involves visits to localities, inspections of restaurants or septic systems, the benefits of regionalization are much smaller because you got to be out there in the field. But these functions that don't involve a lot of traveling to specific sites, all those work well.
John, I would generally agree with Barry, but I would add, I think in part it's something you need to figure out in your area. What skill sets do you have on staff? What issues are of importance that you want to work on regionally? And so I don't know that it should be dictated, and I'm comfortable with a more organic approach as long as people are doing it. And we do know from previous, either with ALFO or FELF meeting, I don't remember, at least a year and a half ago, that people are doing these kinds of things.
All right, anybody else want to take a stab at the regional approach, Elaine or Scott?
Well, this is Elaine, and I think we also have to explore the possibility of a regional approach with some programs like Nurse Family Partnership. It's the only way we really are going to be able to get those services across the state. And we're starting to have discussions here in Spokane about the feasibility of doing that. I think it's going to be tricky, but with modern technology, I do believe that there are ways to have staff out in the field and do supervision on a more remote basis. But I wouldn't just limit it to assessment epidemiology, though I think those do, as Barry said, lend themselves very well to a regional approach.
Yeah, and this is Scott. In addition to what everyone else has said, I agree. I really find it hard to think of something that shouldn't or can't be regionalized. I know in Kitsap, Clallam, and Jefferson, we have a logical region here. Obviously, it works well for FEPR. But Tom Locke is the Deputy Health Officer for Kitsap County, and I'm the Deputy Health Officer for Clallam and Jefferson. So we share health officers in a very regional way. We share epidemiology in a regional way. We send our epidemiologists up to do the same assessments they do here in Kitsap. We actually share environmental health management. We have one of our high-level environmental health managers is actually the PH director in Jefferson County part-time, and then works here, so we standardize policies and procedures between the two counties that way. I mean, I don't really think there's an end to this. I think nurse-family partnership is where we're looking now, is if we don't have the management expertise, can we look to Jefferson County or to Tacoma to provide that so that we can have a functioning nurse-family partnership? And I just, the biggest problem I have as one of the larger counties in that is I can't lose money doing it. Okay, so if I regionalize, I got to be able to cover my costs. So I can't extend a well-wishing arm to other small counties that can't pay what it costs me to send people. That's probably the biggest limitation.
All right, very, very good points made by everybody. Well, this will draw a close to our webinar session. I really want to appreciate our panelists today for taking their time. They're all very busy individuals. And also want to really thank people for taking time to join the webinar. We had nearly 60 people on the webinar today, and I think it just shows that there is, people understand that we're in change right now and wanting to better understand that change, especially from some of our leaders throughout the state, both on the east side and west side of Washington. So here is just some information that we wanted to make you aware of from Washington State Public Health Association. As mentioned by John earlier, we also have a strategic plan and really pushing in the three directions, professional development, advocacy, and also our membership and organizational memberships. So we want to thank you and hope that if you're not a member of Washington State Public Health Association, that you will consider joining us and this movement of really trying to support public health throughout the state in the work that we do. So thank you again for our panelists, and thank you for joining us this afternoon.